Hello everyone in CardioMind's channel, and with a strange title today. When we were discussing the treatments of heart failure with a pharmacological or device therapy, did we really miss something in the treatment? Let's remind ourselves at first with the AHA classification of heart failure. Stage A means that this patient is at risk for heart failure, but without current or prior symptoms or signs of heart failure and without structural heart disease, but he has risk factors to develop this. Stage B, it means that this patient has evidence of structural heart disease like LV hypertrophy, chamber enlargement, resting segmental wall motion abnormality, myocardial tissue abnormality, valvular heart disease, but the patient is still asymptomatic. In stage D, the patient has current symptoms or signs of heart failure due to his structural heart disease, so the patient now is in heart failure. Stage D means that this patient has advanced stage of heart failure with severe symptoms and signs, and so this patient most probably is needing hospitalization and maybe also refractory or intolerant to the medical treatment, and he would require advanced therapies like consideration for heart transplantation or mechanical circulatory support or palliative care. The problem is that we usually miss many points while we manage a heart failure patient, as we usually focus on the pharmacotherapy and device therapy including CRT and ICD, which we discussed of course in detail. So what actually do we miss in the management protocol? First of all, we should focus on primary prevention of heart failure, which means the patient who have risk factors but they didn't develop heart failure so far, and so we need to have optimal risk factor control, heart failure management program including a multidisciplinary approach, patient education and self-care, exercise rehabilitation therapy, and then the follow-up of a chronic heart failure patient. We will start with the primary prevention of a patient who does not have heart failure but you want to protect him or her. Let's enumerate some of the risk factors that increase the liability that your patient may develop heart failure in order to achieve optimal control of them. For example, if a patient is having a sedentary habit or lifestyle, so you need to encourage him or her to practice regular physical activity. If he's a smoker, so you need to advise him for smoking cessation or refer the patient to a clinic specialized in this service. If he's obese, so you need to encourage him for physical activity and healthy diet in order to lose weight. If he's having excessive alcohol intake, you need to advise him for no or light alcohol intake. But in case of alcoholic-induced cardiomyopathy, you need to advise the patient to abstain from alcohol completely. If a patient is at risk for influenza or developed influenza, so he needs to take the yearly influenza vaccination to protect himself. And in case of specific microbes like Trypanosoma cruzi causing the Chagas disease, we need to have an early diagnosis to start specific antimicrobial therapy in endemic areas, and so prevent the development of LV systolic dysfunction. If a patient is receiving cardiotoxic chemotherapy or chest radiation, so we need to follow up the cardiac function and the side effects, adapt the dose according to the cardiac condition, and if there is any LV systolic or diastolic dysfunction, we need to change the regimen after liaison with the oncologist. If the patient is having any risk factors like hypertension, diabetes, or dyslipidemia, so we need to start lifestyle changes and optimal pharmacological control, and we discussed these risk factors in detail in the guidelines of cardiovascular prevention. And finally, in case of coronary artery disease, but the patient did not develop heart failure yet, so we need to advise the patient for lifestyle changes and statin therapy to protect against the risk of cardiovascular events like MI or unstable angina. So the recommendations regarding primary prevention that there is a class 1 to treat hypertension to prevent or delay the onset of heart failure and heart failure hospitalization, and treatment with statins is recommended in the patients at high risk or very high risk for cardiovascular disease or patient with established cardiovascular disease in order also to prevent or delay the onset of heart failure. And SGLT2 inhibitors are recommended in patients with diabetes at high or very high risk For cardiovascular disease or established cardiovascular disease, they are the agents of choice in this case. And of course, we need to counsel the patient against sedentary habit, obesity, cigarette smoking, and alcohol abuse. Let's move now to the heart failure management program, because you are not treating the patient by yourself. It should be within a program and a strategy. What are the characteristics of a heart failure management program? First of all, it should be patient-centered, as here the whole program is focusing on the patient's benefit and the patient's interest. It should be multidisciplinary, so not only a cardiologist, should also include a dietitian, a doctor specialized in the rehabilitation and the rehabilitation nurse, a psychiatrist, other comorbidities that may need optimal control in order to achieve better quality of life, better symptoms, and of course improve the morbidity and mortality. Also, the focus on the program should include prevention of disease progression, symptomatic control by the lifestyle changes and the pharmacotherapy, and maintaining the patients in their preferred place of care for end-stage heart failure, because the patient should be the only one to make his own choice. Also, it should be competent and professionally educated staff working in this, including doctors and nurses, and encourage the patient or the carer engagement in the understanding and the management of their condition. So it is not a one-man show that you are doing by yourself, but it is a team of doctors, nurses, sometimes physiologists, and of course the patient should be included in this management strategy. So, what are the components of a heart failure management program? First of all, it should include optimized management regarding pharmacotherapy, device therapy, and also it should include patient education with emphasis on self-care, symptom management, his medication, how to adjust his medication, and of course the lifestyle changes, provision of psychosocial support to the patient or to the family caregivers, because it is a big burden to have a heart failure patient. That's why psychosocial support is essential. Follow-up after discharge is essential, including in the clinic, including home visits, and sometimes telephone support or tele-monitoring. The easy access to healthcare is essential to prevent and manage decompensated heart failure. Also, appropriate assessment and intervention in response to unexplained change in body weight, for example, increasing weight due to saltwater retention or decreasing weight due to cardiac cachexia. Also, the nutritional status, functional status or symptoms of heart failure, quality of life, sleep rhythm, and sometimes the unexplained change in lab values, especially the kidney function, serum electrolytes, liver function, and blood picture, including anemia. And finally, the access to advanced treatment options in case of stage D in order to deliver supportive and palliative care or decide on the appropriate line, for example, transplantation or mechanical circulatory support, but after discussing with the patients all the options and what is the best for him, and the patient should make his own decision. So the recommendations regarding this program, that it is a class 1, that all heart failure patients should be enrolled in a multidisciplinary management program to reduce hospitalization and mortality, and self-management strategies are recommended to reduce the risk of hospitalization and mortality as well, and either home-based visits or clinic-based programs should be included to improve outcomes and to reduce the risk of hospitalization and mortality. And there is a class 2A, that the influenza and pneumococcal vaccination to be delivered to prevent heart failure hospitalization caused by the chest infections. Now let's move to the patient education and self-care. Sometimes we forget this point and we only give the patient a prescription to take without discussing with him his disease and how to care for himself or herself. Needless to say that the heart failure patient who report more effective self-care have better quality of life, lower hospitalization rates, and lower mortality rate. And this, of course, after the doctor discusses their disease with them and how to care for themselves. So in order to be systematic, what are the main lines of patient education and self-care that you need to discuss with your patient? First of all, you need to explain the disease to the patient and the trajectory of his heart failure in order that he or she understand their disease, the medications that you are going to give them, and what are their benefits, and when are we going to think of device therapy, exercise, and the importance of having regular aerobic exercise plus a sleeping status, the diet, what they need to reduce, what they need to increase in their diet, and what do they need to stop, and the amount of fluids that you need to receive in order to prevent dehydration or pre-renal failure, the smoking and alcohol and their deleterious effect on the heart, immunization and the importance of the influenza and pneumococcal vaccination, sexual activity and how can they have their regular sexual activity with their partner without any symptoms or any troubles, travel, leisure, driving, how can they manage them, the symptom self-monitoring, how can they monitor their symptoms, their body weight, and so change the medication appropriately, psychological issues related to the heart failure, especially depression, and of course the family and informal caregivers should be involved in this education because sometimes they are the only one taking care for the patient and so they need to understand this information. This table was published in the guidelines of 2021, including all of these items that we mentioned before and how can you speak to your patient about them regarding the explanation, medication, device, activity, exercise, sleep and breathing, plus also the fluids, healthy diet, alcohol, immunization, smoking, recreation, travel, leisure, driving, sexual activity, symptom monitoring. All of them are mentioned here with much detail and so the patient can understand how to manage these issues. Now let's move to the exercise rehabilitation that we mostly forgot to speak to our patients about. The guidelines are clear. There is a class 1 for exercise for all patients in order to improve exercise capacity, quality of life, and reduce hospitalization by improving exercise conditioning. So needless to say that exercise is essential for all heart failure patients, and class 2A for a supervised exercise-based cardiac rehabilitation considered in frail patients with severe heart failure or severe comorbidities. So in this case, it should be a supervised training, not just you tell your patient to have exercise. The last item that we are going to speak about today is the follow-up of your chronic heart failure patient. How would you put a follow-up plan and schedule for your patient? The first question, why do heart failure patients need follow-up? Even well-controlled heart failure patients require follow-up to ensure continuous optimization of therapy, detect asymptomatic progression of heart failure by examination, detect any new comorbidities like atrial fibrillation, diabetes, heart failure, and discuss any new advances in care if there is, for example, now an indication for a new device therapy or sometimes adding another medication that may help to reduce morbidity and mortality and improve quality of life. The second question, how often does a heart failure patient need follow-up? The intervals should be no longer than 6 months in order to check symptoms, check blood pressure, heart rate, and the rhythm in ECG for early diagnosis of AF, and also check essential labs like blood picture, electrolytes, and kidney function, and this follow-up to be performed by cardiologist or even primary care physician. Some patients may need more frequent follow-up, like the patients recently discharged from hospital and patients undergoing up titration of medication to have more frequent monitoring. How often do the patients need serial ECGs? It should be done annually in order to detect QRS prolongation, and those patients may become candidates for CRT, conduction disturbance that may need permanent pacing, and of course detection of atrial fibrillation. What about the serial echo? Generally, it is unnecessary because many heart failure patients ask you to perform serial echoes in order to detect any increase in the LV function. But in some cases, it may need to be repeated if there has been a deterioration in the clinical status and to be advised 3 to 6 months after treatment optimization for heart failure with reduced ejection fraction to determine the need for adding new medications or implanted device. Is there any rule for serial biomarkers for follow-up of the clinical status? Undoubtedly, they are good prognostic markers, but the clinical trials investigating their use in order to guide the treatment for heart failure showed conflicting results and no clear role so far, in addition to application of guideline recommended therapy, and that's why there are no recommendation to support the routine use to guide titration of therapy. Only they have a diagnostic role, as we mentioned before in the previous videos. The home telemonitoring is one of the new ways to follow up the heart failure patients recently in order to adjust therapy and seek further advice in some cases, but in this case it facilitates rapid access to care when needed just by telephone, with reduction of the patient travel cost and minimizing the frequency of clinic visits, and so reducing the burden on hospitals. And here there is cessation of face-to-face consultation, as in many countries during the COVID-19 pandemic this was highlighted due to the potential risk of increasing infection with the face-to-face consultation. This is one of the potential advantages of home telemonitoring. How does the home telemonitoring work? Here the patients report their symptoms, weight, heart rate, and blood pressure to be stored in an electronic health record and then to be used to guide patients directly or through the healthcare professional in charge. We need to remind ourselves with this notion that the systems that focus on continuous optimization of care rather than trying to anticipate or manage episodes of worsening heart failure appear more successful, of course. After this information, what is still the gap of evidence regarding the follow-up of heart failure patient? The wearable technology to monitor heart rate, rhythm, or lung congestion have no clear benefit proof at the time being. The cardiac device providing wirelessly and remotely information either on the device working itself, of any arrhythmias, the patient's resting heart rate, or lung congestion, and also monitoring devices that are placed in the pulmonary artery to monitor wirelessly the pulmonary artery pressure. So far they have no clear rule or recommendations. So there is class 2B for non-invasive home-based telemonitoring to be considered for heart failure patients, and also the monitoring of pulmonary artery pressure using a wireless hemodynamic monitoring system, still class 2B, to improve clinical outcomes for heart failure patients. So we have reached the end of our video today, and after this too much information, we need to emphasize that managing heart failure is not just prescribing medication and deciding whether this patient would need a device like CRT or ICD or not. You need to focus on other elements that are needed to optimize the patient outcomes, like the primary prevention of heart failure in other patients, the multidisciplinary team included in the heart failure management program, patient education and the self-care regarding many issues, exercise rehabilitation, and at last the schedule and plan for the follow-up visits with inclusion of the home telemonitoring. Thank you very much for watching this video, and wait for the next video in the heart failure guidelines.